Okay, good afternoon. I started working in the NICU at Columbia since 1973. And that time, neonatology really very primitive. So we have to learn ourselves. So we stayed on a lot of time on the bedside and watch the patient's problem and try to think of how to solve the problem. And if we don't have equipment, we invent the equipment ourselves. Okay, so since then, so today I want to share some of my experience with you today. Okay, not all of them. If you want me to talk all of them, my experience, I need 2 days. Okay, so that's me. Okay, all right, so you can read that yourself. Okay, so I want to talk about how to draw the blood from a small vein, how to put a central line when there's a very small vein, and there's something about temporal arterial line, airway care, how to give epinephrine during the resuscitation from endotracheal tube, and also there's something about PPHN, how to give idle pulse inhalation. So start with those small veins. So at Columbia, always have new people. Every year you have a new fellow, you have a resident, you have a nurse practitioner. And a lot of nurse practitioners come in and they learn to do it, then they go to labor, to hospital, make more money. So we always have a new people. So very quickly they're doing all the vein. Okay? So sometimes when the patient, like oral, you think he's septic, so you want to do the blood culture, you need a lot of blood. So a lot of people just stick the artery, puncture the artery. How about you maybe later get sicker and you need a PPHN line because the oral, they cannot put a UAC in. So I told the people, how to put a vein. So usually you see when we when you put IV, we put this way, right? Okay, so if you try to get a blood sample and you put a needle, that way the blood is come from here to there, right? So your needle actually occlude the lumen, so you have a hard time to get a lot of blood. So if you draw this way, not to put an IV that way, but if you just want to do whole instrument, you want to do a blood culture, you need a lot of blood, so you instead go that way, you go this way. So you put a tourniquet just being bigger, so you put it as soon as you get into the vessel, you take the current way off, and you see the blood keep coming. You can get a lot of blood that way. You don't have to stick the artery, okay? And use a transilluminator will help you to see the deep veins. Like you see the deep vein there, or you can see the artery. Like when you want to put a PPHN arterial line. So I will put a central line. Again, when the people are doing all the vein and now the patient needs central line. Usually they call me, but by the time I couldn't find any vein, I can put an introducer anymore. So I use a 24 gauge angiocat. If I can find the 24 gauge, put a vein, can put a 24 gauge angiocat, I can put a 1 French central line. And all the vein eventually go to the heart, right? Blood eventually go to the heart. So you put a 24 gauge angiocat, you see the blood, then you cut the half off, okay? So then you thread the 1 French catheter, okay? And after you so you estimate or you measure how long you have to push in, and you put it a little bit more. Okay, you put a too deep. You can after X-ray you can remove. You can put it back, but usually you probably don't want to push in further. Okay, and then see this piece of angiocat there. So after then you take this piece catheter out and stay there, but not inside the body, and you tape. So you can put a central line. So I say every vein eventually go to the heart. So sometimes you couldn't get in the extremity anymore. So you can see the vein in the chest or in the abdomen. If sometimes you see the vein, you can put a central line that way too. Okay, like this one. So you put it from actually just from the chest wall, and you push it eventually when way to the the junction. Okay, so I'll put a temporal period arterial line. So sometimes people just new people, then they screw up with the umbilical artery vein. So, and if your baby sick, you need an artery, so you have to put a perimeter arterial line. So you try to use transluminator like this, or you see the radio. So this radio just all night, you only can stick one. And usually you put on the radio, okay? Because there's arcade there, you don't want to, you where this one just maybe occluded, then you put this one, how about just occluded? Again, you don't want to do that, only can do one. And use transluminator, so just look like a started IV, okay? And if all the peripheral vein, radio, even posterior tibia, somebody try, didn't get it, you got hematoma. When you got a hematoma, you want to put a line, it's very much more difficult because the hematoma, so a small artery, so they're swimming inside, you could very hard to get it. So you keep temporal arterial line. Actually, temporal arterial line is safer even than the radio. Okay, the only reason this is not our first choice because you have to save the hair. Okay, but actually that's safer. Okay, so maybe I don't know. Just a computer can can just read the video.
不要照了。你要看这条是，这是链吼。你要看这flow，哦。这里很大的链，那这里阿德在应该在前面。那你现在在照吗？
有在照。
好，这样把它压有一粒嘛，把它压好。哦，看看，不快不？有没有看到这条阿德里？
有。
哦，这样我一压，这就看得更清楚。你有没有看到？
在跳。
哦，好。OK， 把一粒嘛压下去哈。然后这样，那阿口让人家也会更好。这样放了以后，把它放进去，放在这里，放在这里。看到没有？哦，我这样子，然后你放这里哈。Okay, see the pulsation? There's a pulsation there. This is vein. OK， 挂了，小挂了，因为小挂安尼用倒快，上大的。OK。看到血没有？ OK。拿着，一直在。不要冲。
不要冲。
不要
position。
我看很多先冲。比赛。
我应该挂手落啊，但是我那只阿德里挂手落啊，忘较无啊。这里面提。
贴一大片。
一大片，可以冲一下。对，放下，就这样。
这样。冲。
再冲。0.5。
0.5。
你会当同时翕只到这。
OK， 有。
这边干这0.5。我即马，你这忘翕只了，才翕只了我故意甲调冲开，变背起莫变背起，来停着，背来停。所以唔通安尼用，你若安尼不是安尼用，你就0.5。
0.5。你是0.5冲。
0.05。
0.05。
好 ，OK。所以这样呢，较袂叫扭出来。
哇塞，
所以就不会升空了。
不会放来放去。
其实固定头的出来差不多，但是不习惯。
这一边都可以。
Not inside the head. So when you tell the parent, usually because we save the hair, so usually we tell the parent we want, there's no place to put it. We have to put it because this artery is very important. But you don't tell them I want to put it in the head. You tell them I want to put it in the scalp. Okay. You put a brain, they think you want to inject into the brain. Okay. So this external carotid artery, so you have to go in, and then if you go to the brain, have to 180 degrees that way. Okay. Compare with this, if you have the say have a clot, you push it just only 90 degrees. This one and this is tortuous. So this distance is not necessarily shorter than that. And this, if a clot were going, have to go 180 degrees. This is only 90 degrees. So which one is safer? If you had a complication, you like to lose a finger, or you like to lose a piece of a scalp, skin, okay? But this shouldn't happen. If you tape, when you put the arterial line there, you don't cover, you have to see the skin over the tip of the catheter. So if you just turn blue, it's a time to pull. So personally, I put several hundred because a long time I'm the only one at Columbia can put a periarterial line. And there's no complication, okay? And important is, so you save the hair, you heal the artery. If you don't heal the pulse, you use a Doppler. And see where the artery is okay, without the artery here. So you put a finger on top of this and do this, push the edema away, and then you will see the artery. So put this arterial line just like put an IV, okay? And another thing is when you flush, or periarterial line, or the temporal arterial line, the artery very small. So when you get a sample, after you get a sample, when you flush, only use a 1 cc syringe. So you can control every push is very small amount, okay? If you put it too fast, then just small artery, you may rupture it, okay? Or just the whole the area turn white, okay? So only use a 1 cc syringe. So every push, you put 0.05 cc a time. And you look at the area, you just turn white, then you stop and take a second, it disappear, then you flush it again. If everybody keep that temporal arterial line, peripheral arterial line can easily last for a week, okay? And another trick after you put is like this, okay? This is a trick to, when you want to put a temporal arterial line, because most of the time you have some edema, okay? So you have a hard time to see it, okay? So you do this, you will see the artery. So you like put in a temporal arterial line, like put in a IV, okay? And also tell people, the new people, don't practice on the baby. All right, you can put a piece of cord there, and you can practice as many times as you want it, okay? You do it, you push it out, cut it, you can put it again. So practice on this, not practice on the baby, okay? So the airway care, okay? So when you resuscitate, we put a mask over the mouth, okay, the nose, and your back, okay? So the baby's tongue is big, sometimes you occlude it, or your head is flexed, you occlude the airway. So usually when you ambu, okay, you like to see a little chest excursion, so you are ventilating, okay? This is how many, quite often, you see the people use a mask and resuscitate, they don't respond. So I have to intubate. So intubate, as soon as you intubate, do pop, baby pink up. So what does that mean? Because you didn't ventilate the baby, use a mask, and that's because the airway, so you may have to manipulate the neck position, okay? Or use the oral airway, all right? And put the oral airway, you make sure you want to make sure this just to the uvula there, okay? You don't want to go too far, you don't want it too short. So this length is about the mouth angle to the ear. That's the length, the oral tube, that's what you choose to put it, okay? Put an oral airway, or you can put a nasal airway and use the trumpet, that's for bigger children, or the baby that's too big. So you can use the endotracheal tube, okay? So you want to put it just behind the uvula, okay? And that's the length, is from the nose here to the ear. That's the length, okay? So when you put through the nose, quite often, like we all nasal intubation, and quite often the patient go to OR and they try to do nasal intubation because they know we want nasal intubation, and they come back with small tube. I said, why so small tube? Oh, this tube is too big, couldn't go through. No, nasal cavity is huge. The reason you couldn't put a proper size of tube because your direction is wrong, not because. So you just in the case, you put a feeding tube, which is smaller and flexible. So you put this one through the nose first, and then use as a guide, and then you push this so it'll be very easy to get in. Okay, so that's how you use an endotracheal tube as a nasopharyngeal tube. Okay, if you had to try, and you go this direction, right? Not that direction. Okay, and you couldn't advance. You will resist it, not force it. Take it out, put a feeding tube. Put a feeding tube in first, and then use that as a guide to put it. And you put in, see the nose to the ear, That's the lungs. Okay? So of course there's a problem like scalp fracture or the patient CSF leak, people are afraid. But if you use a feeding tube as a guide, that shouldn't happen. If you don't do that, if I push it, you may push the tube that way. And you may go to the scalp, base of the scalp, okay? All right, so if you, or you can use the LMA, okay? So they put a LMA like push the LMA against the hard palate and stay in the middle, okay? If your tongue on the way, you use a tongue depressor, or if your finger push the tongue down and then push against the hard palate. And push a little harder is okay, because that is not something not sharp. And you push it, and all of a sudden you lose the resistance. So you are in the oral pharyngeal cavity, okay? So you are there, all right? And eventually it will be like this, okay? See the airway right at the larynx, okay? If you put a fiber optic bronchoscope through here, you will see very easy go into the trachea. And that's sometimes the people, in adult people, when they couldn't intubate, they put an LMA in and put a fiber optic bronchoscope through there, and you can easily get into the trachea, and then to change the tube, trachea tube, intubate that way, okay?
Janet keeps giving me this. Giving me checkbook.
Recording now.
Okay, so you can treat you, all right? Okay.
But the one you trust her? She don't know how to run a movie camera.
Hey, my kid.
That's your kids, not you.
See how easy could doctor put that in.
Yeah, but he's the only one who does what you do.
He's the only one who can do it anyways. Very good. There you go.
He showed us the first time.
No, Dr. Wung, now, during the night, this deflated. It was flat before. We'll discuss that later.
He's complaining.
You know?
We got 5 people holding me down.
He's strong, though.
Oh,
What do you need?
Another piece.
another ticket there? Let's look at another side of midnight there.
when I leave, you can finish cleaning the whole day.
You have to give her part of your paycheck, Harriet.
Nah.
I know, nurse. I have to do it slowly.
Don't shake.
Now I have to make an angle. And your humidifier.
That's okay.
I just need some water.
So like this, the patient tracheal current, okay, those kind of patient airway obstruction, you can put oral airway, and put oral airway, or like a PA-1 sequence patient is very anterior, very difficult to intubate, okay? So you have just a patient and have severe airway obstruction, you can try intubation. That's fine, but you will find out very difficult. You will try one time. If you don't see anything, don't keep force it. Otherwise, then you create edema or create breathing, will be make it worse. So you just put a Airway in, okay? And like this patient, so we put you put a Airway in for 24 hours, okay? And then you take it out. You clean some secretion and watches how the patient is breathing. If still obstructed, you put it back. Usually it takes 3-4 days. The patient get the peripharyngeal muscle getting stronger because usually Airway baby can cry, okay? So they can get stronger. If you intubate it, so they don't exercise their parapharyngeal muscle, so you extubate they're still obstructed. But you use Airway, sometimes some of them like 3-4 days, then you do that every day, and eventually you see, hey, there's no more obstruction, okay? Or if you have people is less experienced, junior people, and they on call, you are not there, and they have a problem, intubate the patient, they can put an Airway in, okay, and wait until you come, okay. So like all this kind of patient, this all PA-1 sequence, and you say Airway, then they don't have a, okay. So I had a video, but I didn't see, okay. So how about endotracheal tube intubation? So endotracheal tube suction. So like this patient, this patient, he was on respirator and it's fine. And then he getting worse, even he couldn't ventilate the patient with a tube. So you had to take the tube out, change the tube, and look at what is tube. There's a plug all the way down there. And why the plug is there? Because they suction, they only suction up to here. Okay? See, you have a foreign bodies here. You irritate it, you create more secretion. Also suppress the serial motion, so they don't move the secretion up, and patient cannot cough. So you have a tube there, you need suction, okay? And the secretion don't jump to the tube for you to suction. So you have to go around to get it, okay? Not like this, okay? All right, so when you want to suction, you want to use as big a suction catheter as possible, because our patient's tube is a 2.5, so you use a 6 French, is 3 or 3.5, you want to use 8 French suction catheter, you want to as big as possible. So whole instance, you have 3, so you suction from here, because this inside the tube, and lumen becomes smaller, you have problem put an 8 French. But if you put from here, you're able to put 8 French. And so we suction from here. If you from here, even you can get in there, but it's much tighter, much harder to push the length you want, okay? So this patient transferred to us for ECMO. Okay? A lot of people think this patient had pneumonia. This patient was 70 miles away from Colombia. If this is all pneumonia, I don't think he will make it to Colombia. Okay? So I know a lot of people are afraid to suction the patient. So we suction. One time, couldn't load the respirator fast enough. Of course, he doesn't need ECMO. Okay? So when we suction, we say secretion is dry. So must have some more. Okay? So you see the secretion there. Okay? You the patient on respirator. And he was fine. And then he become agitated. Okay? When he agitated, the patient tried to tell you something. And this is a baby. You know, like an adult, he may want something, so you fake it, you know. But this is a baby. They have problems, that's why they're agitated. And most of the time, the people, oh, he's agitated, give us sedation. Why he was doing well, and why all of a sudden he become agitated, okay? So usually, trust me, usually that's because of secretion. Patient want to survive. That's why, okay? So at Columbia, we told our nurse, you should, when you see that, you quickly check to make sure respirator is okay. And if you don't see anything fine, usually that's a secretion, and you should suction. And usually when after suction, the patient quiet down. So very rare patient on respirator at Columbia had a sedation, except if they have a surgery, okay? So if your patient on respirator become agitated, so usually suction first, okay? And suction is not just to put a suction catheter in the endotracheal tube. You have to pay attention to the length, okay? So like this patient, when he was okay, his x-ray like this. When he had agitated, he had problem, and that's the x-ray like that. Okay? So this is somebody suction, didn't suction properly. That's why. All right? All right, so you have to suction, so you suction every 2 to 4 hours. You depend, so your patient, you suction, say you suction every 2 hours, and there's not much secretion, then you can every 3 hours, every 4 hours, okay? And they say you now is every 4 hours, but before every 4 hours, he agitated. You don't want anything wrong, you should suction patient. And before you suction, you increase oxygen, okay? And you may increase the respirator setting, so you just increase oxygen. And if this tube humidity not enough to dry, you drop the normal saline or saline water before you suction, or duplicate your suction catheter with that, okay? And when you suction, try to see, go to the length you want. As soon as you get there, quickly get it out, okay? All right, so I say secretion, don't jump to the endotracheal tube for you to suction. You have to go around to get it. So we are sucking membranous, okay? I know you go to you go to the Google about the endotracheal tube suction. They tell you don't suction beyond the tip of the endotracheal tube because otherwise you're going to injure the mucosa. Okay? So there's a paper do that long time ago. So we look at all our patients that time with fibrotic. Our patient, the trachea is like a tunnel. Okay, we don't see the bleeding, anything like that. If you see say some bleeding, then your humidity not enough, or your suction catheter to reach it, change the other components of catheter. Okay, so you want to get there. Okay, so usually you 1 kilogram, 1H3. So tube maybe up there, you H3 to there, and there's 2 membranous, right? If a bigger one, you can go 5. And I test this way when long time ago, when the baby's late, when I start to lose this, when we get the X-ray, when on the dead baby, okay? And we do this, and usually they will suction catheter way up to there. And why we do this? Because one day there's a premature baby, okay, it's like 600 grams, and he's ready to be extubated, but now it's a sunset. Last time we don't extubate patient before sunrise or after sunset. So we say, all right, we do it tomorrow morning, first thing in the morning. Next morning I come, bed is empty. I said, what happened? Oh, this patient, massive hemorrhage, and couldn't resuscitate, he died. So at autopsy, there's a suction catheter perforate the lung, and that's why. Okay, that's why we say, oh no, we have to measure the length, okay? And we want to go in there, so you have to measure the length when you suction. So you go far enough, and you don't go too far perforate the lung, okay? All right? So there's a two main bronchus, so suction at least twice. You want to go to the right side, you turn the head to the left side, so this has become more straight, okay? And you then suction, you have not much secretion, okay, this side is okay. Then you want to suction the other side, turn the head, you go back to the respirator, let the auto start decouple a little bit, and then you turn to the other side and suction the other side, okay? So that's how we suction the patient, okay? So they extubate. So when you extubate, you have to extubate patient as soon as possible, okay? So whatever the reason he was intubated, and that's a condition is already resolving and patient is stable. And patient, the IMV rate is not high, and the patient is active, and there's a spontaneous breathing. So all our patients usually on respirator is SIMV plus pressure support, 5. That's all the resistance intratracheal tube. So almost our patient on respirator, I always see they had a spontaneous breathing between the respirator cycle, okay? So if you do that and your patient there, so he breathes okay, so I ask a nurse, and baby sleeping. So I ask a nurse, so when you suction, there's a lot of stimulation, right? Did he move? Oh yeah, he's moving, he like want to sit up. Or he can do that, he can strong like that, he can breathe. We extubate the patient. Okay, but sometimes just a very tiny baby. So you think he's okay. Okay, later, 1 hour later, you want to say, okay, now we have a time, we want to extubate the patient. So you do a blood gas, and CO2 will go higher. So the people are afraid to extubate the patient, and because this, and that's patient maybe because he needs suction. That's why he dictated CO2 go up. Or, the endotracheal tube just a variable, right? So sometimes the head position and the variable against the tracheal wall. And that's why the CO2 go higher. But you just patient, sometimes he's good and bad, there's no such a disease. So when I see it, I ask the nurse, when you suction, is he very, very active? Oh yeah, he's very active. Pull the tube, okay? So don't dip the tube there just because the secretion like that, okay? So before we suction, before we extubate, of course, tube still there. You want to take opportunity to clear the secretion, okay? Still on respirator, so you increase the oxygen. If the rate already low, you increase the rate. And with laryngoscopy, take a look, okay? And quite often, the more or less had edema. So we paint with epinephrine, okay? Use a Q-tip and laryngoscopy, and you paint it, and then you pull the tube out, you secretion, you suction, and you see the vocal cord is moving, okay? And why we do this? See, in 1973, in 1970, so, and then some of you probably had this experience. How you do when the meconium must be, there's a meconium. So usually, that's a standard of care. is laryngoscopy and suction the tube, right? Last time? And who go to do that? The resident. So we have to teach the resident how to intubate. So how we intubate, teach them. So when the patient want to extubate, patient stable. So we let them laryngoscopy. Anybody can do laryngoscopy, can extubate, can intubate. Okay, that's how we do. And we supply, they said quite often the diagnostic edema. And that's why we start to paint and we start to do almost routinely laryngoscopy and paint before we put the tube out. And our success rate, when I extubate patient, I expect 100% success, not like a 30% failure after extubation. Okay? Believe me, you patient, you just pull the tube out and you extubate, and there's severe retractions. That's the upper air obstruction. Take a look before you intubate, or you prepare to intubate, but take a look first and color epinephrine, and you see that edema, you paint it, and you may no need to intubate them. Okay? So that's how we intubate. Okay, so sometimes, just less now, sometimes we have patient transfer, maybe because they give us surfactant. So you have to give us surfactant before the first breath, right? Remember when that started? People say that, of course, nobody can do that before the baby take a first breath. But quite often the patient intubate, they put it tube maybe in one side, and you may put the surfactant on the other side. The patient has problem, you keep increase setting, and you will see this. So the first patient transfer to us, transfer to our thoracic surgeon. So thoracic surgeon, this is a baby, and you want me to do pneumonectomy. Dr. Wung, what do you should do? I said, let me do one-arm ventilation, okay, because that's acquired, okay? So you put a strong hands of catheter, there's a balloon there, and you inflate this, and endotracheal tube there. This alongside endotracheal tube, not inside, okay? So you ventilate, so the air only goes that side, didn't go this side. So this will absorb, okay? So this smaller, okay? And you overdo a little bit, okay? So now this is gone, then you don't inflate anymore, another 24 hours, then this will be expand, but not like before, so much emphysematous. Then you know the cure, and then you take the strong against the catheter out, and then you follow up. So this patient doesn't need pneumonectomy, okay? All right, so epinephrine. So what you, and where the book tell you when you resuscitate, how you give epinephrine. They tell you disconnect from here and put a 0.1 epinephrine through the tube in ambu, right? Of course, that doesn't work. Then now they tell you put a 0.3 cc from there and ambu. Of course, it doesn't work. You give epinephrine to the tube. You put a 0.1 or 0.3, just stay there. You ambu, you didn't get epinephrine in. Okay, no wonder it doesn't work. Okay, so we know how to give, we want to give to the patient. So give to the patient, and we know how to give a surfactant. So we will, when the patient near epinephrine or the endotracheal tube, such as hemorrhage or during resuscitation, we give it. We will have a feeding tube and cut to the tube, and we inject from here, and you have a little bit air behind, so you spray it will create lot of contact area, and will work, because when I do that, all our patients become tachycardia. Okay, see, so think what you are doing. Okay, all right. So PPHN. Okay, so just one time we had a transcutaneous PO2 electrode before the O2 SAT. So we can see the PO2 and we record it. See, what do you find? See, when the baby cry, this is not because you stimulate them, okay? They breathe more, when they sleep, go down. When you nursing care, such as change the diaper, you wake him up, go up, When you sleep went down, you suction, you stimulate, they go up. When they sleep, they went down. Okay, that's what you find. So who said the PPHN patient should be paralyzed, should be sedated? You make them worse. Okay? So when we see that, and this time is pre-scoring, that's before NO time, and when you see almost 99% you give pre-scoring will work. Okay? So you give pre-scoring, you couldn't lower this PO2, couldn't lower the FiO2 fast enough. Okay? So in order to control the pulmonary artery pressure is endothelin pathway, nitrous, and and use prostacyclin. So usually, these adult people doing pneumo, but we want like to give a from inhalation. We want to the medication go only went to the lung and no systemic effect. Okay, so usually we start with the NO, right? All right, so use the NO, like, okay? So you may want add sildenafil so they don't break down, you have more cycle GMP to relax the bases, okay? But 30% PPHN patient doesn't respond to NO, okay? So you need plan B, okay? So the next one is we try prostacyclin, all right? Or you can use a Minilong. So use your Minilong so they don't, you have more cycle AMP may help, or you use prostacyclin to relax, okay? So you will use this aero nap. So what is aero nap there? There's a membrane there. So you put a medication, they push through the membrane, and there's a membrane there. There's a 1,000 of very tiny pore. That's a 1 micron size. So the medication, you push the medication through here, come up just 1 micron. So this is very small and all the way down to the alveoli. Okay? So you want to give a medication really go into the lung, you use a aero nap. Usually the ACON, that time you see a daughter, a very big particle, that's all stay in the upper airway, didn't really get to the patient. So if you serious want to give the patient medication, you should use aero nap. Okay? So when we give aeropause, so you get from here or go from there. This is proximal tubing, and this oscillator because it removes CO2 so effectively. So a little bit tighter volume, a little bit less space is okay. But if you conventional, you no one put it here, you want to put it there. So don't increase the dead space, okay? So you put medication there. So you aeropause, you dilute it. It's 1 cc, they give it 1 cc, it's a 10 microgram. So you use a 2.5 to 5, okay? And you dilute with normal saline to make a 2 cc and go through the aero nap, okay? So adult people, they use every 3 hours, 6 to 9 times a day when they have the patient pulmonary hypotension. But aeropause is a half-life is 20 to 30 minutes, okay? So you have a severe PPHN patient, all right? You give it 1 bolus, then lasts 30 minutes, 45 minutes. Then you have to keep giving. You end up giving a lot of medication, and you see when you give it, PO2 is a distant response. Okay, then it goes down, you give more, and get a lot of medication, and you still see this up and down. So half-life is 30 minutes. So we was is a bolus, and if we show response, then we go to continuously. Okay, go continuously. Okay, so you use a syringe pump, and you pump this through this aero nap, and because you run out, pump only 2-3 cc an hour. So this is very small, so you make sure this tubing have to extend to drop right at the membrane. If you don't do that, then they stay in the wall, but take forever to get to the patient. Okay, so it's very important. If you want to use a yellow nap and use hold it continuously. You make sure you have this tubing extend to drip right to the membrane, okay? All right? Like this. So if a conventional respirator, so you put in the expiratory tubing. If you are oscillator, you can put it there, okay? And you have this tubing drop right into the, on top of the membrane, okay? So you will see this after bolus should improve continuously. You don't see O2 to go like this anymore. And you end up, you have a safe, rather, you don't have to use so much isoprose, okay? All right, so again, all right, so when you put it, you, as I say, this yellow nap had to be put in this way, proximal side, there. Not to put there, otherwise increase this space. This patient mistake was put on here, and you see his respiration rate. Because on top of his CO2 is high, he had to breathe spontaneously. You see the respiration rate. When I see that changes, see the respiration rate went down. Okay, all right? All right, so now when you give an NO, right? We all give it from here, right? So you go from here because there's hot wire. You want to measure the flow, and we mix it, and that's hot wire, so cannot have the water condensation there. So you put in before the humidifier, okay? So that's how you give it NO. But some of the RT, when you want to give aeroport, they will give from here too, okay? And see, if you go from putting it here, then the patient get it this much. If you put them here, just 12 inch from the tip there, then you get that. If you put it right here, and that's like what I say, in proximal side, you put a much more medication. Okay, so it should be put there, not there. You put it there, and all our patients had tube leakage. The nurse get more than the patients. Okay, thank you.